is the atrophy and ischemic change of the tips of the fingers. And here's someone with sclerodactyly, which is the explanation for the vasospasm. So you may or may not have a diagnosis from taking a history, considering the probabilities and seeing whether the examination then accords with your first thoughts. But very often you can't find the explanation immediately. So looking at the urine, the white cell count, routine biochemistry, is there any evidence of myositis? Is there any evidence of renal failure? Are there abnormal, are there casts in the urine? Are there cells in the urine? Dipstick, is there protein in the urine? Chest x-rays, any evidence of previously undetected fibrosis? ECG, is it atrial fibrillation or not? And then Doppler. Now, in many institutions where I work, easy access to Doppler is possible, and it's therefore easy to further evaluate someone with evidence of digital ischemia by looking at the larger vessels in arms or legs to see if there is any occlusion higher up, or indeed a plaque that might cause partial stenosis and is a potential explanation for embolic disease. Acute phase response, serological tests to explore for connective tissue diseases, ANF and complement, and then antiphospholipid antibodies before you start treatment, because lupus anticoagulant is difficult to detect. Anticentromere and topoisomerase antibodies, if you're thinking about scleroderma. Cryoglobulins, in my institution, cryoglobulins are very hard to detect. So if you think you need to detect for cryoglobulins, get someone like a medical student or a redundant member of your team to run off to the lab with the sample quickly before they precipitate in the pool, a rheumatoid factor. So a simple range of investigations that can be quickly performed within the first few hours of a patient presenting with digital ischemia. You would want to admit, I hope, and then the investigations can be organized, including angiography, but that may be done via CT or MRI or MRA angiography. There may be reasons why you want to explore the chest and the abdomen, looking for any pathology, but especially cancer, if there isn't an answer. But these are things that may not be done within the first 24 hours or even 48 hours. So let's just consider for a moment of the patient who appears to have an embolic explanation. What you may find, other than atrial fibrillation, is some evidence of endocarditis. So you may find the patient is febrile, there may be splinter hemorrhages, but all too often the classical features of endocarditis are absent. The chest x-ray may be abnormal, there may be cardiomegaly and the hint of aneurysmal dilatation, and that's when echocardiography comes into play. Does the patient have endocardial thrombus? You can also exclude atrial myxoma by the same mechanism. The aorta, is there widening of the mediastinum? Could this be an aneurysm, on which again is associated with thrombus formation and emboli? Is there aortic thrombus anywhere in the aorta? Then you do get reasons for upper limb occlusion, which may be the site of thrombus formation and subsequent emboli, such as outflow obstruction in the thorax, subclavian aneurysm, and of course atheroma, much more common in the legs, but can arise in the arms as well. In the legs, popliteal aneurysm, cystic adventitial disease, which may cause aneurysm, and atheroma most of all. So this is a patient who's actually got atheroma in the superficial femoral artery, and he's throwing off small emboli from that source, who has all other investigations. This is a patient who presented with these toes and for whom we simply could not establish a cause, ever. It's all right thinking, it's all right investigating, organizing investigations, but you need to get on because there is a need to try and preserve as much viable tissue as possible. And this is the immediate management. You need vasodilatation, intravenous iloprost, low molecular weight heparin. These are the medical approaches. If you establish early that the likely explanation is emboli, then early intervention by a vascular surgeon with embolectomy, possible angioplasty if there is narrowing of a large vessel in the arm or leg, and endarterectomy if there's obvious atheromatous plaque on which clot is formed. There may also be a need, especially in the legs, for early macrovascular reconstruction, bypass surgery, in other words. So all of that is dependent upon thinking of the right diagnosis, urgent investigation, and early diagnosis. There's some obvious things on this slide, which you may have picked out of the history. The smoker, no matter what the causation, never again. If the patient's on a beta blocker, stop it. If a patient turns out to have antiphospholipid antibodies or lupus anticoagulant, then no need to delay in authorizing the patient. You've already started low molecular weight heparin. You may have to use unfractionated heparin, of course, if the patient has renal impairment. Give corticosteroids until you know what you're dealing with. You may have to consider using cyclophosphamide if the patient has a connective tissue disease like lupus,